Great to be able to speak to you guys today about C Diff. It's a field that has been changing recently. It didn't change for many years. So yeah, we've got some interesting things to discuss, and I'll move on from there. So C Diff, we know, causes quite a large spectrum of disease. This basically extends from asymptomatic carriage right through to hemodynamic collapse and death, with the kind of pathognomonic toxic megacolon and pseudomembranous colitis towards the end. We know that also one of the major issues with C. diff is that it is quite frequently recurrent. People will often recover from it, but then have another episode, often within a few months. It is the most common infectious cause of antibiotic-associated diarrhea, and most often it is hospital acquired. Also, it is one of the most commonly acquired hospital infections. So if we look at a study that was done in the US looking at all specific pathogens causing hospital-acquired infections, C. diff is right there at the top, and along with other pathogens like Staph aureus, E. coli, Candida, and Enterococcus. So it really is one of the most important hospital-acquired infections. In terms of its history, it was first isolated back in 1936 by Hall and O'Toole. It got the name initially Bacillus difficile because of its difficulty in isolation and culture. But it was only really in 1978 that George and colleagues associated it with human disease and realized that it was actually the organism that was responsible for a lot of antibiotic-associated diarrhea. Then in the 2000s, there was a steady kind of increase along with the discovery of the NAP1B1 ribotype 027 strain. That caused a number of outbreaks and an increase in cases worldwide. Also, there was an advance in diagnostics with PCR at the time, which may also attribute to some of the increase in cases during the 2000s. And then in 2016, it was transferred from the genus Clostridium to its own genus Clostridioides, with the only other member of this genus being the Clostridioides mangonotii, which is not really associated with human disease. So it's a gram-positive anaerobic spore-forming bacillus. It is motile, capsulated, and flagellated. And for the microbiologists, it's catalase negative, indole negative, and hydrogen sulfide positive. And it's generally the part of the gastrointestinal biota of healthy people in about 3% of the population. Some studies say up to about 5%, but this is much higher in populations that live in congregant settings such as care homes. And it can exist in both spore and vegetative forms, and this is very important for its transmission. C. diff causes most disease through two toxins, toxin A and toxin B. Toxin B is far more virulent and thought to be the main toxin responsible for disease. Not all strains of C. diff are toxigenic, so those that do not encode the toxin do not cause C. diff infection. And that's important to know when it comes to understanding how we diagnose C. diff. We know that stool levels generally correlate with disease severity, so of the toxin. So more toxin around, the more severe the disease is. And that's also shown in the reason why the NAP1B1 027 strain is hypervirulent and has been implicated in severe disease and also recurrent disease and in specific outbreaks. But this strain also produces another toxin called binary toxin. Part of the reason why it's so pathogenic is another gene called the TCD-C gene is associated with generally suppressing levels of toxin expression. But in this particular strain, there's a partial deletion of that gene, which results in basically increased expression of the toxins and more severe disease. So toxin A and toxin B can bind to a receptor on the top of the colonic enterocyte. This receptor is called poliovirus receptor like 3. It gets internalized and then acidified, and through an action on RHO and RAT GTPase affects glycosylation and inactivation of proteins within the cell, which results in breakdown of these tight junctions. This causes an epithelial integrity breakdown, which is associated with the disease. How is it transmitted? Well, like many other fecal oral transmitted organisms, either from someone who's had C. diff themselves and hasn't washed their hands, or from other surfaces where you've contaminated hands and then transmitted to other people. And ultimately it is ingested and then colonizes the next individual. It's highly transmissible, partly due to this ingestion of spores that are quite resilient in the environment. If you look at a hospital environment, it can often be cultured from multiple different surfaces and different medical equipment, and particularly from the hands, clothing, and medical equipment associated with healthcare workers, particularly stethoscopes. Importantly, the spores are not killed by alcohol rub, and that's something that we'll reiterate, that I'll reiterate later. And it's very important to realize that cleaning your hands, particularly in the time of COVID, it doesn't, with an alcohol rub, doesn't necessarily or doesn't really get rid of the spores, and that does not stop transmission to another patient. So patients that are either colonized or have C. diff associated infection can be a source of transmission to others. Now, there are other sources of transmission. So as I said, those that are colonized but are not actively symptomatic. Other non-hospital associated healthcare settings like care homes. There's a query about environmental reservoirs. Patients who are contacts of other or people who are contacts of patients at home after an admission for C. diff, or contacts of healthcare workers can possibly have it transmitted to them. And then there's been some cases of zoonotic transmission from certain animals. So what are the risk factors for C. diff? This is kind of a nice simple image from the CDC. Includes antibiotic exposure, older age, recent exposure to healthcare facilities, weakened immune system, and a previous history of C. diff. So when we're talking about antibiotic exposure, the antibiotics that are most frequently associated with C. diff would be your fluoroquinolones, clindamycin, penicillins, and your cephalosporins, particularly the 3rd and 4th generation. Carbapenems are also included there. And then you can see from this table other antibiotics that are associated with C. diff, but it's also important to realize that almost any antibiotic can be a precipitant or can be associated with C. diff, but these are the main culprits. This is a nice table that is more exhaustive from the South African Journal of Infectious Diseases. This is from the South African C. diff guidelines by Trusha Nana and her team, that was published by the South African Society of Clinical Microbiologists. And so it gives you a bit more detail as to what the pharmacological, host-related, and other clinical intervention risk factors are. So how does C. diff actually cause disease? Well, if you look at an individual that is healthy and has been exposed and has asymptomatic colonization, we can see that there are multiple factors in place that kind of contain C. diff. The one thing is an acidic pH in the stomach can kill C. diff spores and also prevent them from germinating. The commensal bacteria in the gut convert primary bile acids to secondary bile acids, which themselves inhibit C. diff growth and prevent germination of the spores, as well as competing for C. diff for kind of food substrates as well. Bacteria also produce bacteriocins, which can inhibit C. diff. And then you've got your immunological factors, both soluble and cell-mediated factors that may be associated with control of C. diff. So then when you have certain insults or changes to this homeostasis, you can get disease. So the one would be exposure to C. diff spores through a healthcare facility or consuming food or from fecal oral route. PPIs controversially, but are quite consistently associated with a higher risk because they increase that pH that we spoke about that would kind of contain C. diff spores. And then obviously the major issue is change or depletion in the commensal bacteria, and this is often associated with antibiotic use. By depleting those commensal bacteria, you don't get the conversion of primary bile acids to secondary bile acids. There's loss of competition with C. diff itself, and you get pathogen expansion, release of the toxins, which include the toxin A, B, and the binary toxin I mentioned, and then barrier dysfunction and disease. So in terms of the epidemiology, it's a problem worldwide. This study looked at mainly rates in the developing world with an average rate of about, or mean rate of about 4 cases per 10,000 patient days. This is mainly from the developed world. If we look for those countries that there was longitudinal data from, we saw that for up until 2012 in the US, we saw a bit of an increase, whereas for Canada, we saw a slight decrease, and for the rest, it was pretty much stable. And this is up until 2015, at least from this paper. Another study from Asia showed similar rates of C. diff with rates of about 5.3 cases per 10,000 patient days. In terms of local epidemiology, there's not a lot of data out there. A study in 2013 showed about 8.7 cases per 10,000 hospitalizations. Also, the units that are used are inconsistent between different studies and quite difficult to compare between different studies. A study done at Charlotte looked at C. diff in hospital cases and found 154 cases over 18 months. High proportion of them were hospital acquired and quite a high mortality rate, but we don't know how many admissions there were and during that period of time in order to give a kind of comparable assessment of incidence. Frederick also another study from there in 2015 showed that 16% of patients with symptomatic patients, when they did stool PCR for multiple different pathogens, found that 16% of them had C. diff. And then there was a study from Donald Gordon between the years of 2013 and 2016 that showed rates of pretty consistent with international rates between kind of 6 and 8 cases per 10,000 inpatient days. But generally, the trends in the developing world have been changing in terms of total cases of C. diff. It looks like they're starting to reduce. That's the data from America. This is another 2 different studies from the US that showed healthcare-associated C. diff seems to be, at least in the bottom picture, they're reducing a little bit, in the top kind of stable, and community-associated C. diff either stable, slightly increasing, but as a proportion of total C. diff seems to be increasing slightly because the hospital-acquired C. diff seems to be decreasing slowly, and it's community-acquired either staying the same or slowly or slightly increasing, resulting in an increased proportion altogether. So how big is the problem? Well, this study looked at what generally the length of stay was for across multiple different studies, and showed that it was around about 8 days for the index case in hospital of C. diff. If they had a recurrent stay, a recurrent case was increased to about 9.3 days. And if you looked at propensity matched cases, having C. diff, in addition to whatever other reason brought you to hospital, increased your length of stay by up to 3 weeks in some cases. And of course, this comes at a huge cost, financially and in terms of resources at the hospital. So this study looked at number of visits per patient with a single case, with 1 recurrent, 2 recurrents, and 3 recurrences. And obviously, you get an increased number of ED visits and an increased number of inpatient visits associated with each recurrent case. This then translates into huge increases in cost. So these are American stats and not directly able to be transferred to South Africans, to the South African environment, but about $70,000. The cost is over a year, over 12 months for a single case, if you're considering pharmacy costs, outpatient costs, and inpatient costs. And that obviously increases the higher number of recurrences there are. So obviously, it is a massive problem in terms of cost and burden on the healthcare system. This is a study from South Africa, from the Western Cape, looking at 4 different hospitals, which also looked at not just the cost associated, but what about mortality associated with a positive C. diff result. They looked at samples that were sent to the NHLS for testing of C. diff, and then looked at mortality. And they showed that those samples that were C. diff positive, those individuals had a higher mortality at 30 days than those that were C. diff negative. And when they included all this, a number of other factors in a logistic regression, they found that basically the odds ratio is 4.7 if you had a positive C. diff result versus a negative result. Other factors that were associated with mortality at 30 days were obviously critical care admission and tuberculosis as well. So apart from higher costs, longer hospital stays, there's also a significantly higher mortality associated with this disease. So how do we diagnose it? Generally, it's important to consider what the specific case definition of C. diff is. And these are directly from our South African guidelines, which are really nice and clear and very similar to the 2018 IDSA guidelines. So a case would be an individual who develops diarrhea whilst in the hospital for more than 48 hours, or if an individual presents to a hospital with continued diarrhea for about 3 days and where appropriate stool testing has not detected a pathogen, or patients with presented to care with diarrhea with any of these other risk factors that we mentioned earlier. So overnight stay at a healthcare facility within the last 12 weeks, antibiotics, other risk factors such as IBD, solid organ transplant, etc. What are the ways to diagnose C. diff? Well, there's a number of different tests that can be used. The reference standards are toxigenic culture and cell culture cytotoxicity neutralization assays, which are not used frequently at all. But they are the reference gold standard. But the tests that are freely available and used most often would be your nucleic acid amplification tests that target the toxin encoding genes, such as your PCR, a GDH antigen test, which is used quite frequently, and then toxin A and B immunoassays, which are also quite frequently used. So the South African guidelines suggest a two-step testing algorithm, either detecting the GDH, which is a C. diff wide common antigen amongst different C. diff strains, so it doesn't prove that you've got a toxigenic C. diff, or starting with a nucleic acid antigen test such as a PCR. So if we look at the top, if you have an individual who is GDH negative and is toxin negative, that's simple. That means that the patient does not have C. diff. If GDH is positive and the toxin is positive, then we know the patient does have C. diff because we've proven that there's C. diff there and that there's toxin being produced. If they are GDH positive and toxin negative, then we know that there is C. diff there, but it may not be producing toxin. So it may or may not be a toxigenic strain. And at that point, you can do a nucleic acid test. And if that is positive, then you can say, if it is negative and the GDH is positive, then we can say that there's toxigenic C. diff there, but there's no detection of free toxin. If the GDH is positive and the toxin is negative, and the nucleic acid antigen test is negative, then we can say C. diff is absent. The other option is to do a PCR first. If the PCR is negative, then we can say there's no C. diff. If the PCR is positive, then you don't know whether this toxigenic C. diff is actually producing toxin or not, and then you can do a toxin immunoassay, which if is positive indicates C. diff, and if it is negative, we would say that there's toxigenic C. diff there, but that the toxin has not been protected, but it's not been detected. So this up here on the right is an immunoassay that's commonly used in the NHLS, which would detect the GDH antigen with a line on the left of your screen, and when it detects a toxin with a line on the right. So that would indicate that the patient who is symptomatic has got C. diff. So the PCR, whilst very sensitive and having a very good negative predictive value, can sometimes confuse you because, as I said, it shows that you've got that toxigenic C. diff is present, but it doesn't tell you whether there is actual toxin being expressed and being produced that may be causing disease. So they did a study, this was done, I think, at Stanford, where they looked at patients that were symptomatic, and they did a PCR for the toxin, and then they looked at patients that had formed stool, that were asymptomatic, admitted to the hospital for another reason, found that 15.4% of those that had symptoms had positive by PCR, and about 12% of those that had formed stool were positive by PCR. So it just indicates that basically that just having that some patients in whom you may detect toxigenic C. diff may just be asymptomatically colonized. So here they looked at the percent positive, and then even when they're looking at the actual cycle thresholds of the PCR, there's quite a significant amount of overlap, indicating that it's quite difficult to use a PCR test alone. And that's why often it's suggested to use a two-step test where you prove both that the C. diff is there, a toxigenic C. diff strain is there, and that the toxin is being actively produced using an immunoassay of sorts. So I just wanted to move on to management of C. diff. The first thing would be including infection control, so isolating a patient if you can, putting them in their own room, or if not, cohorting C. diff patients together and making sure you use appropriate PPE, being a gown or at least an apron with gloves, that you use appropriate hand washing using soap and water, and that the room is cleaned using appropriate agents. Very important is to stop the inciting antimicrobials if possible. Often the reason why the patient is on antibiotics is because they have a particular condition. So sometimes it's not possible to stop them. But we know that stopping the inciting antibiotics generally reduces recurrence, reduces severity of disease, and helps resolution. And then the ways to treat C. diff would be using antibiotics, and we'll go through that now, microbiota targeted therapy, toxin targeted therapy, and then obviously surgery would be the last resort when indicated. And that's beyond the scope of this talk, so I'm not going to really talk about the different surgical options and when you would use that. It's important to assess the severity of C. diff. And now there's no globally kind of agreed upon criteria, but these are the criteria suggested in the South African guidelines and are taken from the American IDSA guidelines. So basically mild to moderate disease is patients who've got a white cell count below 15 and normal renal function. Severe disease would be a higher white cell count, above 15, or deranged renal function. And then fulminant disease would be association of shock with ileus or megacolon. So that's important when it comes to choosing the type of treatment required. So in terms of antimicrobial therapy, we've really got three drugs, metronidazole, vancomycin, and fidaxomicin now. There's been a shift away from using metronidazole towards using vancomycin first line, and we'll discuss that, as well as a shift in the US away from using vancomycin to fidaxomicin first line, but I'll discuss that and the reasons for it. So the first question is, why a shift away from metronidazole to vancomycin? That's generally because there's been quite a few trials now that have shown vancomycin to be superior in terms of, particularly in terms of severe disease, but in terms of cure. There's no clear difference on recurrence rates between vanco and metronidazole. In 5 randomized controlled trials, including about 800 patients, vancomycin was associated with 87% cure versus a 78% cure for metronidazole. So fidaxomicin then, it was basically the first new drug to be used in C. diff for about 31 years. It was first approved by the FDA in 2011. What's useful about it is it's orally delivered and it's got minimal systemic absorption. It's highly active against C. diff, but also it's got a very narrow spectrum of action with limited action against commensal flora, which can't be said for vancomycin. From this study, which looked at pre and post, looked at your microbiome pre and post vancomycin, you can see that there's a complete wipeout of most of your intestinal flora using vancomycin. This persists for up to 22 weeks. Even after 22 weeks post vancomycin, there's still deficits, or your intestinal commensal flora have not recovered completely. And so that's where the specific benefit of fidaxomicin can be seen. So vancomycin versus fidaxomicin. So if we look at, for an initial case of C. diff, the only difference is in a sustained response to C. diff at 4 weeks. So if we look at clinical cure rates, drug adverse effects, and all-cause mortality, we can see that none of these differences were statistically significant. We can see all the confidence intervals across 1. But the only real benefit is basically in a reduction in relapse post initial treatment, and that is significant for fidaxomicin. So basically, for every 1,000 patients treated with fidaxomicin, basically between 100 and 150 patients fewer would relapse if using fidaxomicin versus vancomycin. That's for an initial case, and for a recurrent episode, it's pretty similar. Also, showing that with 3 randomized controlled trials, a sustained response to C Diff, sustained response to treatment was present more often amongst individuals who received fidaxomicin. So basically, in terms of initial cure, that the differences are not significant, but in terms of a sustained cure, fidaxomicin from these studies is clearly superior. The problem, though, is obviously the cost of fidaxomicin. So this was taken from an American presentation, showed that for fidaxomicin, the cost to an individual often not covered by their medical aid in the US was close to $5,000, whereas vancomycin liquid was about $70. There they can get capsules as well. We don't have access to the capsules, as far as I'm aware. And I would guess that our vancomycin is a lot cheaper than that. And fidaxomicin in South Africa costs between 14,000 and 18,000 Rand a course. And it is available. It's available at Charlotte. I think it's available at a few other hospitals in the state sector with particular reasons and with specific motivations. But that's the major cost. Is the major issue with fidaxomicin is its cost at the moment. So what about metronidazole? Should we throw it out? Can it be used? I mean, lots of people are still using it, aren't aware of the fact that it's not indicated as a first-line treatment. But it still does work generally. This is a big study done amongst veterans in the US using about 3,600 patients that had a failure rate of about 10% for initial mild disease. When they looked at and analyzed the factors associated with success, generally younger patients did better. So basically in mild cases, young people, people who are having a first episode, and where there are costs or accessibilities to vancomycin, it's a reasonable alternative, and particularly in our situation. And other cases that it's used is in fulminant disease, and we'll go through that as part of the guidelines. So what about fecal microbiota transplant? So if we look at what happens in C. diff disease, here we've got a patient who is healthy with undisturbed microbiota, and here we've got a patient with disease, with multiplication or growth of C. diff. By using antibiotics, all we're really doing is eliminating the organism itself. The disturbance in the microbiota is not really changed. And so the theory of fecal microbiota transplant is that once you've treated and removed the C. diff, if you were to try and replace this, you may have a more sustained cure. So it's not a new thought. Fecal microbiota transplant thoughts have been for thousands of years, have been around for thousands of years. Hippocrates apparently said death is in the bowels, and that poor digestion is the origin of all evil. And we also know that gut dysbiosis nowadays, we know that gut dysbiosis is associated with multiple human diseases. We're obviously just focusing on C. diff today, but there are multiple other diseases that have been associated with gut dysbiosis, and it's a field of ongoing and very active research. So there's some evidence from Chinese medicine that in the 4th century, there was a well-known Chinese medical doctor who was called Ji Hong, who treated patients who had food poisoning with a human fecal suspension called yellow soup. I mean, I don't know how many people he cured or killed using this this approach, but it is recorded in the literature. Then another Chinese medical doctor recorded the use of it to treat abdominal diseases as well. In the West, from the 17th century, there's an Italian anatomist who was called Acquapendente, and he used enteric bacteria transplanted from a healthy animal to restore sick animals to health and vigor. And he called this transformation, which I think is quite a nice word we could maybe repurpose. And then in terms of kind of modern medicine, the first case of a fecal microbiota transplant was in 1958. Dr. Eisman used fecal enemas to treat 4 patients reported to have pseudomembranous colitis. So at the time, they didn't really realize why it was working, and they hadn't yet identified C. diff as the cause, but it was one of the first reported success stories of FMT. Some of the early data shows that there were lots of small studies done, kind of observational studies that didn't provide huge amounts of robust evidence. But if you add them all together, it showed that generally, amongst early studies, that FMT was highly effective, at least amongst these cases, showing resolution in about 92% of cases. The first randomized control trial was published in 2013, and this showed that people with recurrent C. diff, if they were given a donor infusion of feces, had a much better recovery than individuals given vancomycin. And this was basically the basis for FMT. And there's small numbers of patients, but quite significant differences in those patients that received FMT and those received vanco, and those that received vanco with bowel lavage as well. Also not associated with many significant adverse events, apart from just some kind of from diarrhea and some other kind of non-specific abdominal symptoms. And that also showed that in terms of the microbiota diversity that was restored after the infusion, compared to those patients who had C. diff before the infusion, kind of agreeing with the principle of FMT. So basically, most of the evidence for FMT is in recurrent C. diff, and there are multiple different studies published with rates varying from 76% to 90% in terms of cure. A few studies have compared vancomycin to FMT, but lots of the protocols differ. The specific treatment used that was compared to differ, but generally quite good success in the literature has been shown, particularly in recurrent C. diff. So that data is reasonably robust, but what about for a first episode of C. diff? Again, multiple studies have been published, most of them small kind of observational studies, but there's one randomized controlled trial that only had very few patients. I think it was 7 in the FMT group and 9 in the vancomycin group, and compared FMT as an initial treatment for C. diff, and found that there was lower cure rates amongst FMT than the vancomycin group. But you can clearly see that this may be an area that may change with time. So for now, there's no evidence for use of FMT as an initial treatment for C. diff. So what are the potential harms of FMT? Well, there's been a few cases of fatal aspiration pneumonia. I think it's been about 3 that I know of reported in the literature. This was one where a patient was given FMT, had an aspiration during the procedure, and then developed a fatal aspiration pneumonia, and pretty soon, within a few hours of the procedure, and passed away. Then there have been a few different cases of transmission of drug-resistant bacteria from a donor to an individual who's receiving the transplant. Often these individuals are not healthy, they've got multiple other comorbidities, and this has resulted in the death of at least 3 patients. Last year, there was an FDA warning against alert about serious adverse events related to transmission of pathogenic organisms, and this was due to transmission of pathogenic E. coli in about 6 patients, 2 of which died. And that's prompted rules to be made. Well, they found out that these donors actually at the time were not screened for ESBLs, and that has now become mandatory as part of FMT in the US, and it's pretty, I think, worldwide as well. What are the other off-target effects of FMT? The bad ones, as I said, would be transmission of drug-resistant organisms. Sometimes colonic complications, perforations when it's given with a colonoscopy, aspiration pneumonia, as I mentioned, and also you don't think of a change in drug levels that may be associated with change in your microbiota, particularly using drugs like warfarin. And then there's a lot of unknown effects. We don't know. We're learning more and more about the role that your microbiome plays in particular diseases, and then we don't yet know exactly what the damage may be if you change the microbiota. In this case, it seems most of the time to be pretty effective and positive. But there's just some things that we just don't know. Other benefits, in some cases, FMT has actually resulted in the eradication of multi-drug resistant organisms, fewer bacteremias and UTIs, weight gain, improvement in non-alcoholic fatty liver disease, and increased microbial diversity. Also, post-FMT, individuals are more resistant to being colonized with C. diff again. So how should it be given? There's lots of different studies, and not all of them well-powered, but looking at how whether one route is better than another. This was a recent study looking at giving oral capsules, so capsulized fecal transplants versus colonoscopy, and showed that pretty much it was non-inferior. So that's quite a useful finding, because there are obviously certain dangers associated with giving your transplant via a colonoscopy, and also enables things to be done as an outpatient more easily and cheaper. And then fresh versus frozen. Can you are frozen stool samples used equal to fresh? And this is quite important if you're wanting to know whether it's feasible to set up a stool biobank, and you could possibly use super donors that could be used and to treat multiple different patients. And this study showed that there was that using frozen compared with fresh did not result in any worse proportion of clinical resolution. So that was quite positive as well. So then how do we select donors? Because this is quite an obviously important part. If you look at, these are the European guidelines for FMT, donor selection is quite rigorous, and even almost more rigorous than blood donation. And they suggest using basically two different interviews. One is a preliminary interview to identify suitable people, and then another interview is done right just before on the day of donation to check that nothing's changed. And you're looking at multiple different issues that range from exposure to different diseases, use of different drugs, risky sexual behavior, transmission of blood products. I mean, the list is quite extensive. And then, of course, you've got to actually screen the blood and the stool of the individual, apart from doing the actual interview screening. Generally doing all the general blood tests that you would expect, looking for different transmissible viruses, other pathogens as well. Then also testing the stool, one for C. diff and for other pathogens. And this is almost one of the most important things, is to make sure you don't transmit live pathogenic bacteria to an individual that is already immune suppressed. There are South African Gastroenterology Society guidelines as well. These were published in 2015. They are a lot easier to read and shorter, and they're worth a quick read if you're interested. So they have a protocol also for how you identify the donor, how you should screen them, how you actually prepare the stool, and how the transplant is done. So a 2-page document that's very quick and easy to read. I've basically copied all of the documents into this slide. It can be found at that link below. So what local experience has there been of FMT? Not a lot published. This was a study from Donald Gordon, and here they transplanted 27 patients with recurrent C. diff. They were mostly older than 65 years and female, or there were a third of them were older than 65 and were female. They did most of these as an outpatient as well. And they reported resolution for all their patients at 4 weeks, unless there were no recurrences. They said, and they reported that there was no morbidity. They did these transplants via nasogastric tube, which in some ways can be risky and was sometimes not done because of the risk of aspiration. But they did pick up that there are multiple difficulties, particularly this is a private institution with using FMT as a treatment. And one of the issues is that it's not yet set up for funding in the private sector. So there's no particular code for FMT. So what that means is that doctors then have to use other codes as kind of for proxy procedures. which is not completely ethical, but is one way to bill. And there's also huge variations in the cost to the funder, and so many medical aids won't pay for it. Also, the big issue is often where you don't have a stool bank is how you identify the donors. And in this study, I think they were all family members or friends, and there were one or two donors were previous donors for other patients. So the cost, there's a huge cost in as you can imagine, screening these individuals for in order to obtain safe samples for transplant. There's also other issues in South Africa and indeed around the world around the ethical and the legal framework for FMT. These are a series of 3 well-written, very interesting articles that are published in SMJ last year and are worth a read. Basically, they look at the legal regulation around microbiome-based therapies, because basically regulatory challenges in the US have been quite a big hindrance to why FMT is not quite widely adopted. And they approach questions like, is human stool tissue, or is it a drug or medicine? Which part of the National Health Act does it apply to? And they propose some different ways of approaching FMT in the meantime, until the regulatory framework kind of catches up. So these are a couple or 3 interesting articles that are worth reading when you have time, or found in the SMJ. So we spoke about FMT, we've spoken about antibiotics. What about Beslatoximab? So this is now toxin-based or based therapy. So Beslatoximab is a monoclonal antibody against toxin B. There's also another monoclonal antibody against toxin A called Actoxumab. And the reason why this was developed was to try and prevent C. diff recurrence in patients that are receiving antibiotic therapy. And the way it works is that it would bind and neutralize toxins, and then prevent them from binding to the host cells. This then prevents new C. diff symptoms in the setting of regrowth, and then helps the healthy gut microbiota to reestablish themselves naturally. So the landmark studies that looked at using Beslatoximab was the Modify 1 and Modify 2 studies, which showed that when used along with the standard of care, that the rates of recurrence were much lower amongst individuals that were given Beslatoximab in both these trials. So Beslatoximab is the darker color here. And rates of recurrence were much lower. But when Beslatoximab was given with Actoxumab, or Actoxumab was given on its own, these results were not. When Actoxumab was given on its own, Actoxumab did not add anything to it, and when it was used on its own, it didn't show any particular benefit, which may also indicate the fact that toxin B is what is most important, not so much toxin A. If we look at all the factors, all the participant characteristics that were associated with success, or with basically a decent difference when compared to placebo, those that were older than 65, if we looked at those that were immunocompromised, seem to have benefit. So that has resulted in a recommendation within the 2021 IDSA guidelines that in patients with a C. diff episode, Beslatoximab, they suggest using Beslatoximab as a co-intervention along with standard of care antibiotics rather than standard of care antibiotics alone. But again, this is a big issue because the cost of it is massive. It's given, it's a monoclonal antibody, and it's basically a cost of, I think, close to $20,000 US for a course. And in most individuals, that doesn't really make sense from a costing perspective. Although there was one study that showed, written by Merck, who I think are the guys that actually made the monoclonal antibody, showing that for some people it can be can be cost effective if you consider the rate of recurrence over time. And if you can kind of put your mind back to those costs that I showed you earlier, there in some cases, it's possible that it may actually be worthwhile. So what about probiotics? It would kind of make sense that if you were to give some bacteria along with or just after you had your antibiotics, that maybe you could speed up the recovery of your microbiome. There has been one big study using, I think it's close to 1,700 patients, 1,500 patients that showed no difference in the use of probiotics to reduce C. diff in a hospital. And then this one interesting study took a bunch of people and wanted to see what the effect of using probiotics on antibiotic-induced gut depletion of the microbiome. And they took individuals, gave them antibiotics, they gave them ciprofloxacin and metronidazole for a week. And for one group, they gave them an autologous FMT. So they took stool from them before they were given antibiotics, stored it, and gave it back to them afterwards. The other group they gave probiotics to after they'd received antibiotics. Another group they did nothing to. They just let them recover on their own. And then they looked at the gut species and looked at their recovery. And what they showed was that those that were given an autologous transplant in brown and those that were given nothing in red actually had much quicker recovery of the microbiome than those that were given the probiotics, which was interesting and kind of counterintuitive. So in this case, probiotics actually slowed the recovery of their microbiome. So how can we summarize all of this? It's a huge amount of information, I know. So I thought the easiest way would be just to look at our guidelines and just go over it again. So in terms of South African guidelines, which are very easy to read, nicely written, I recommend that everyone has a look at them, published in the SA Journal of Infectious Diseases last year. For an initial episode, the recommendation is vancomycin for a duration of 10 days at a dose of 125 milligrams 6 hourly. And this is for non-severe, or for Dexamycin. If they are not available, then you can use metronidazole. If it's severe case by our criteria, then basically it's the same treatment, but you would try not to use metronidazole if you have any way not to. Then if it's fulminant, generally you can increase your dose to 500 milligrams 6 hourly. And you can use intravenous metronidazole. And the reason for that is that vancomycin in someone who has got fulminant disease may have an ileus. Vancomycin does not, if the vancomycin not getting into the gut or into the colon via an enteric route, it won't get through IV, whereas metronidazole can, if given IV, can get into the colon. So that is an indication for using metronidazole. And also you can consider using vancomycin in 100 mils of normal saline as a retention enema. So remember that in patients that are vomiting. For recurrent episodes, if you have been using a vancomycin for the initial episode, they suggest fidaxomicin. If you used metronidazole for the first episode, they suggest vancomycin. And if you used vancomycin for the first episode but don't have access to fidaxomicin, then they suggest a prolonged tapered and pulsed regimen of vancomycin. So that's important to remember as well. And that would mean using vancomycin over a longer period of time, so 125 milligrams 4 times a day for the usual 10 to 14 days, and then reducing that dose to say 2 times daily for 7 days, then once daily for 7 days, and then reducing it further. And that helps to reduce recurrence. And then if there's a third or subsequent recurrence, they suggest FMT. If you don't use FMT, otherwise fidaxomicin or vancomycin in a prolonged tapered and pulsed regimen. So how do the American guidelines differ? This is from the IDSA 2021 guidelines. The one is that they now suggest that for an initial C. diff episode that you use fidaxomicin rather than a standard course of vancomycin. So this is looking at the evidence available, but not really considering the cost. And so they say here, this recommendation places a high value on the beneficial effects of fidaxomicin but its implementation depends on available resources, and vancomycin is an acceptable alternative. They also suggest Dexamycin for first line for recurrent C. diff, pretty much the same reasons that I highlighted earlier. But obviously, these are all affected by cost. And for this reason, these guidelines have been a little contentious. And then they suggest using Beslatoximab as a co-intervention along with standard of care antibiotics with a very low certainty of evidence. And again, they say this places a high value on potential clinical benefits, but that implementation may be limited by feasibility. So what other things are on the horizon? One would be other drugs like Randomized, which is a non-absorbable small molecule antibiotic. DAV 132 is like a activated charcoal that aims to absorb colonic drugs such as the fluoroquinolones and prevent them from causing damage to your microbiome. Other microbiome therapeutics, cultured mixtures, bacteriophages targeting C. diff, and vaccines, but none of them have really shown to be very effective. And then other mechanisms to try and predict individuals that may get C. diff, and then trying to make the appropriate prophylactic intervention to prevent that from happening. Briefly on prevention of C. diff, generally we should try and assess our patient's risk. This means looking at antibiotic exposure, previous exposure, looking at the age and how long they've stayed in the hospital environment, and also any immunocompromising conditions. And then these are kind of figures from the CDC, which initially aims to use antibiotics appropriately. And remember the high-risk antibiotics that I mentioned earlier, clindamycin, fluoroquinolones, and third and fourth generation cephalosporins. And then diagnosing it, identifying and isolating patients, protecting, using appropriate PPE, and then obviously cleaning the surfaces and preventing spread appropriately. So, and that's it. So if there are any questions, I'll be happy to take them. I know I've gone a little bit longer than I expected.
Cool. Thanks very much, Lyle. That's a really good overview of the issues, and nice to see as well the differences locally and internationally in that. We've got a couple of questions which are coming through. So one is about isolation of the patient. So in long-term healthcare facilities, how long should patients be isolated for? And I suppose probably similar answer in hospitals, I guess.
Yeah, so I think the guidelines are all very different, and a lot of it depends on what your isolation facilities are. So some people will say as soon as you finish treatment and the diarrhea has stopped, 2 days post after a single or two formed stools, you may then de-isolate the patient. But we do know that that shedding of spores may continue for a period of time. So where you can, some hospitals will isolate people for the whole course until they're discharged. But I mean, it's not always feasible to do that. So I mean, at a minimum, it would be until the patient's completed treatment and has been, and would be say 2 days. Some would say 2 days post their last kind of loose stool. But the guidelines are very variable and does very much depend on what your circumstances are. It's kind of difficult to isolate people for very long where they can't really, where they've got restricted facilities.
Thanks. Then the question about the monoclonal antibodies of Beslatoximab, the question is about the duration of therapy.
Yeah, so it's given once. I mean, the half-life is about 19 days, I think, and they have detected the antibody in the serum for up to 3 months thereafter. So it's generally should give you protection for up to about six months thereafter. But yeah, it's generally, it lasts a long time, and generally should just need to be given once after an episode. We don't have it available in South Africa; it's not registered here, so we can't actually get hold of it, I think, outside of a kind of study.
Yeah, and I was going to say the one other thing about the study which showed the decreased recurrence is that almost no one was on Dexamycin in that study. So it does,
Yeah.
again, the benefit would be smaller, in a population using Dexamycin, which is another huge implication. I mean, I don't think it'll ever come in terms of the cost effectiveness of it, and it would be very difficult to see it ever being cost effective, which is a pity in some cases, but it's not.
Yeah, I mean, the other thing also is that they didn't really, what has that kind of extended pulsed regimen of vancomycin is quite effective at preventing recurrence, and that regimen hasn't really been used in some of these studies. So those are other options. So it looked quite, like you said, quite significantly better, but in the era of Dexamycin and this pulsed tapered regimen of vancomycin, it may not be as effective.
Yeah.
Comparatively.
Then the question is, does the state have oral vancomycin available? And in addition, if the patient becomes asymptomatic, can they isolate at home if they're able to because of bed shortages?
So from what I understand, I spoke to the pharmacist the other day, at least in my hospital, and we don't have the oral vancomycin tablets that they have in the States. I spoke to our gastroenterology team as well, and they said that from what they're aware of, we've only got the liquid vancomycin, which can then be used, diluted into water and drunk kind of 4 times a day in a particular volume once you've worked out your dose. So from what I'm aware of, we don't have an oral tablet form or capsule form. Maybe other people are aware of them, but I'm certainly not. And then, sorry, what was the other question again?
About if they're asymptomatic, could you send them home early?
Yeah, sure. So, I mean, patients can go home. I think at the pharmacy, they can be given, can be taught how to mix their vancomycin and can go home with the vancomycin ampules to go home. And then obviously they need to be taught about the hand hygiene. They can be taught how to kind of clean surfaces at home using, I think there's on the CDC website, they suggest using bleach and like a 1 in 10 solution on surfaces at home. So yes, they can go home. They don't necessarily need to be there until the end of the duration of therapy.
So the tablets are available in the country in the sense that they're registered, but they are expensive. They are about 5,000 Rand for a 10-day course, as opposed to somewhere about 200 Rand for a 10-day course if you use the intravenous form and mix it up orally. So it's unlikely, again, I mean, this, in terms of cost-effective analysis, that's going to make its way into the States. Certainly, if you had the money, it would be nice to swallow the tablets rather than mixing them. It tastes a bit bitter. Apparently, if you mix it with orange juice, it goes down well enough, though, if you take the intravenous stuff. I mean, the issue is the cost with all this. For Dexamycin is astronomical. It's about 16,000 Rand for 10 days, which is just never going to be cost-effective, not even in private. It's somewhere near insanity. And it's, even if you build in an extra admission or two, you still end up well down, which is a real pity. Again, if it moves, I mean, again, that it moves price-wise, it could be looked at again. And then ask about FMT in the South African public sector. Do you think it's possible to expand access in the public sector?
Look, it is available. The problem is at the moment it's done on a kind of patient by patient basis. So whenever someone needs it, at least from our experience at Joburg, if someone needs it, then it's about sourcing a donor, screening them, getting the stool, doing the transplant. When we have a better set up stool registry or biobank, stool bank, I mean that will make it a bit more feasible. Also, particularly if you can capsulize it and get to that kind of technological side of it, it makes it a lot easier because it's not particularly difficult. It's just the main issue is just having donors and screening appropriately. And I do think it is possible to do to if you have someone who's going to take that initiative to get a whole bunch of donors, screen them properly, store the stool appropriately. There's no reason why we couldn't expand it. The expensive part is obviously the screening, and the rest is not particularly expensive.
No, I agree with you. We've done a couple here at our hospital, but again, it just it requires a bit of effort because it's not set up for it. But you can be done, and as you said, potentially more doable, ironically, in the state, given the limitations you mentioned in terms of billing and who pays for the screening that in the private sector. It ends up being a family member almost always because no one else wants to donate the stool, but that can be done. And then a really good question about from Eunice was asking about the Beslatoximab therapy. He's saying, does it work on the luminal side of the gut? Because it's quite a good point. You're giving something intravenous. Does it work intraluminally?
I mean, that's the way I understand it to do, because I mean that's where it can access toxin and bind it and prevent it from attaching to the lumen of the. So I mean that's the way I understand it to work.
Yeah, I was going to say me too. But yeah, it's a good point. I hadn't really thought of quite the mechanistic. Yeah, it's a good point. And then from Terry in Cape Town, so the person is C Diff antigen negative, toxin negative, then NAT C Diff positive, but toxin negative. Am I reading it right?
Yeah.
Sorry.
Yeah, sure.
Should we consider treatment? Because his understanding is, do we take into account how they are clinically?
Yeah, so I think, I mean, previously in the US, for example, they were treating anyone at one stage, so treating anyone who is symptomatic with a single step algorithm, not using a dual step algorithm.
Sorry, just confirm, you meant antigen positive. So in other words, you got GDH positive, toxin negative, but NAT positive. How would you treat that patient? So in other words,
yeah. So I think it doesn't really change. It would be similar to someone who was NAT positive alone. If you're not detecting the toxin and the patient's asymptomatic, then you wouldn't treat. But if the patient is symptomatic and you can't find another cause, then you may consider treating. But you would generally expect it to be able to pick up the antigen if it's if the toxin if it's at decent levels.
Yeah, it's a common problem because the toxin is only about 70% sensitive for so you end up with this problem. And as you say, in the end, it all comes down to the NAAT at the end, the PCR anyway.
Yeah.
Acknowledging that you'll overtreat some if you do it that way, but it's hard otherwise if they're symptomatic. Very tough. And then final question, because we are a bit out of time, but how long should patients continue to practice meticulous hand washing? So that's related, I suppose, to the first question we had about isolation periods.
Yeah, I mean, I don't know the exact guideline. Generally, a lot of these tests they've done, some of them have checked for, and this is not what we should do, but in clinical trials, they've often done tested for C Diff after resolution, and generally there's no C Diff after about a month post initiation of treatment. But I guess we should always be practicing meticulous hand washing. I don't have a specific answer in terms of how long, how many days you should be doing it. I think as soon as you kind of asymptomatic, a few days thereafter, you generally are safer. But I guess we do know that you can still shed spores and may possibly infect family members.
Yeah, I agree. I think that's a really sensible answer. It's interesting. I mean, the spores definitely are resistant to alcohol, and one sort of almost dirty secret is that every time people have looked in the actual hospital setting, it doesn't seem to make a difference whether you use alcohol or soap and water, but we still kind of preach soap and water, and that's probably a good general rule, at least. But one collateral piece of damage sometimes is that in hospitals which move to soap and water universally, they actually found much less hand hygiene in general because it's so much less convenient. So it's kind of very difficult to balance.
Yeah, they suggest that where you have an outbreak setting that you change all hand washing to kind of soap and water, but also a specific point being made is that no hand washing technique has eradicated spores from people's hands completely. So that's something to be aware of, and that you should always be, for that reason, you should always be using gloves. And then you should thereafter make sure that you wash your hands with soap and water.
Excellent. Thank you very much, Lyle. That's a really nice overview and fielded a huge amount of questions. So thank you so much for your time.